ننتقل إلى المتحدث التالي البروفيسور نور الدين، أحد الهامات المتميزة في طب القلب في اليمن، يمتعنا بحديثه عن Where am I from Diabetologist and a Cardiologist perspective in managing diabetes. تفضل يا دكتور نور.
شكرا جزيلا for these introductions، وشكرا لمؤتمركم العظيم في جمعية السكري والغدد الصم، وشكرا للرجل العظيم اللي قاد المؤتمر، فأتمنى له التوفيق ودائما مميز وبجهد ذاتي، أسأل الله أن يعينه دائما. So at the beginning, it was putting a questions in mind. What am I from Diabetologist? كطبيب قلب يسأل What am I from Diabetologist? فit is big questions، وعشان بس نحل الديليما احنا فين وهم فين، فهذا غرض المحاضرة. كان cardiologist perspective on managing the diabetic patients. So what are the debate between both of us? So every one of us, you can see from different way. This is 9 or 6, it's a coding. ويمكن جيت أنا والدكتور زاهد بتصايح إن والله this is my patients, this is not your patient. Then he'll say to me, this is my patients, it's not your patients. So how we solve the things? So the diabetologist, he said his patients, cardiologist, his patients. So we can reverse this dilemma. This is your patient, even it could be my patients, and any one of us can replace the others in management. ونلتقي على مودة. So the idea, I have nothing disclosures regarding to this talk. It's a matter of meeting from the Cardiac Yemeni Heart Associations with Yemeni Diabetics Associations, and a good meeting should be there. So the beginning can say to you, diabetes increase the cardiovascular risk, reach nearly 2 to 4, and the other most patients with diabetes will eventually need cardiovascular care. If you see from the previous talk how they are integrated. Most cardiac patients benefit from diabetes screening and management, and it should be done for these patients. Diabetes and cardiovascular system disease are interwoven epidemics, so they are connected to each others. Cardiologists frequently encounter diabetic patients first. Collaboration is essential who manage what and when to refer these patients. If we see the continuum of cardiovascular system in diabetic patients, simply start like this. Genetic susceptibility, environmental factors, nutrition, obesity, physical inactivity, insulin resistant, or all other parameters is there. Hyperinsulinemia, diabetes, blood levels of lipids, atherosclerotic change, and hypertension. Then it will go to obvious diabetes and its complications. Then finally it will end to disabilities and death. By all things is going through the cardiovascular system. وعشان كده they thought that the diabetes, it is endocrine, cardio, renal, metabolic syndrome. So it's not one system disease. If you think to these slides, how it will be. So what are the cardiologists prescribed and what are the diabetologists prescribed? If you see cardiologists, number 4 drugs, they are diabetic drugs in their prescriptions. If we see the diabetologist, number 2 of their prescriptions is cardiovascular system drugs. So this is why the companies, the drugs company, play with these rules. ولما عملوا study which doctors are prescribing more, they find these 2 categories of doctors they prescribe more. So what are the scope of cardiologists in diabetic management? Cardiologists usually focus on heart and vessels. So he's screened for diabetes in a cardiovascular system in cardiovascular disease patients. And then he managed the risk factors, hypertension, lipids, weight, and smoking. Then initiate cardioprotective glucose lowering drugs like SGL2 inhibitors, GLP-1 receptor agonist, and metformins. This is also can play with diabetic and cardiac patients. Again, it provides acute management during acute coronary syndromes or heart failures. The cardiologist is interfering in these things. So what are the scope of diabetologists in managing cardiac patients? The diabetologists focus on glucose and its metabolism. So treat diabetes, obesity, and metabolic syndrome. Design rigid oral drugs, insulin, combination therapy. This is their business. Again, monitor and treat the cardiovascular complications, neuropathy, retinopathy, and nephropathy. So how we can integrate between the two systems and two doctors? What are the drugs? Cardiac drugs affecting glucose. Usually, all of you know these facts, that beta blockers can mask hypoglycemia. Again, thiazide can worsen hyperglycemia. Statin, small dose, they said it is diabetic risk. Like in all of these, it is risk-benefit things. So it's not a simple words as it is put in. The anti-diabetic drugs impacting the cardiovascular system, the SGLT2 inhibitors, it's, as you know now, it decreases the risk of factors of heart failures, and then it may lead to dehydration, ketoacidosis. It could be just kept in mind. GLP-1 receptor agonist, it is safe when the cardiovascular benefit for atherosclerosis, like in take care of GI side effect. Metformin is called the coronary stone drugs it used, so it be used in patients. Try just to be considered how much the glomerular filtration rate. Even so, we can play in such situations. Sulfonylureas, insulin, just think of hypoglycemic effect and weight gain, as you know before. Albeoglitazones to be avoided in heart failure patients, especially they are giving more fluid retentions. This is the different categories of drugs can be play a role in two systems: beta blocker, thiazide, statin, SGL2 inhibitors, GLP receptor and agonist. So this is again key benefit risk way of management in such situations. The questions again in cardiologist mind: how much I get the target of hemoglobin A1C if I treat patients and not refer him to the diabetologist. So keep in your mind, if he's younger, low comorbidity, so keep the target hemoglobin A1C less than 7, establish atherosclerotic disease 7 to 8, and then if patients had advanced heart failures and advanced chronic kidney disease, you should just keep the target hemoglobin A1C 7.5 up to 8 and avoid hypoglycemic effect. So what's right I'm going to do? What's wrong I'm going to do? So how far can cardiologists manage? Cardiologists can manage it in these situations. So he can initiate SGL2 inhibitors, GLP antagonists, and then especially if there's patients have advanced cardiovascular events, heart failures, or chronic kidney disease. Continue metformin. It is safe. Adjust cardiac medications to reduce metabolic harm. It is also safe in such situations. Again, set the hemoglobin A1C 7 to 8 in a cardiovascular system patients. So what Trump said? No, and it is wrong to do these things. Wrong that the cardiologist should not do these things. Initiate or titre complex insulin regimen. This is for diabetologists. Then the other thing, manage severe hypoglycemic alone. Again, optimize multiple drugs regimen. This is diabetologist things he should do it. So again, the cardiologist, when to refer the patients cardiologists, when to refer a patient to diabetologist. So if you have just newly diagnosed diabetes, need complex therapy. This is diabetologist way. Poor control despite basic therapy, so you can refer the patients. Frequent severe hypoglycemic effect, again refer a patients to diabetologist. Insulin initiations require, this is a diabetologist way. If there is complications like neuropathy, retinopathy, nephropathy, this is a diabetologist management. So I've just to give you very short case. A1C 8.5 with GFR is 65. What we are going to do for these patients, so the cardiologist can interfere in such situations. So it's better to start SGLT2 inhibitors and then later on refer the patients. Patient like these patients, 70 years old with HFpEF and insulin, recurrent hypoglycemia. This case, immediately you refer them to diabetologist. If a patient is stable in coronary artery disease on hemoglobin A1C 6.8 on metformin, what you are going to do for this patient? Simply, this patient, let him to continue and no need to refer the patients to diabetologist. So the global model between both of us, the diabetologist and cardiologist, it should be like that. The cardiologist, he'll think of cardiovascular outcomes, risk reductions, and basic therapy. The diabetologist, what he should do, he should just control glycemic control, complex regiming, and to treat the complication. This is in the short way how we can do both of us. أصله قريب جنبي. So the idea of these things, it is a matter of team-based care, what we call joint care and best outcome for the patients. The other points, share the guidelines, the American Heart, the European, the Diabetic Association's guidelines. So we should share of these to manage patients and get better and best outcome. So my take-home message that cardiologists should screen, initiate cardiovascular benefits drugs, and set realistic hemoglobin A1C goals. Be aware of drugs interactions between cardiac and diabetes therapies, then refer when control is poor and there is a complications appear or insulin is needed. Collaborations, avoid under treatment or over treatment of the patient. What I can say to you in one word, the key message for all of these things, neither specialty can work alone. Joint care prevent both under treatment and over treatment, reducing the mortality and morbidity of the patients. What they said, cardiologist is the heart of diabetic patients. Diabetologist is the diabetes of a cardiac patient. So this is just the final remarks which you kept in mind. So we have both of us to work to stop diabetes. وفي قبل ما صفقوا الآن specialty, it's called cardio diabetology. It is new specialty. Anyone he can enter in this field. برضو نتمنى أن نلقاكم في مؤتمر القلب العسكري القادم 16 إلى 18 ديسمبر، ومع تحياتي لكل المنظمين والمشاركين في المؤتمر. شكرا لكم. مالك أنا جبته معايا في كل محطة، أصلا هو كان جنبي فإحنا جالسين نعمل محطة.
شكرا بروف نور على هذه المحاضرة الرائعة وعلى اختيار الصور الجميلة. ايش تعرف من اللي يختار لك الصور دي؟ بس يعني اختيار موفق وفي أماكن معبرة عن الحب والصداقة.